Yes. So we're talking about running injuries. Running, as we all know, is pretty popular. We all get to learn how to run as a child, and that is where we learn how to run, but it also develops along the way into what we turn into a sport. Why is it still popular? Well, it's a pretty inexpensive workout compared to SoulCycle and other gym memberships, Equinox and whatever. And as such, basically running has been skyrocketing in popularity. Every year, many more runners. We see this both locally as well as nationally. I think the Brooklyn half sold out in less than an hour this year, which was a new record for them. So definitely running is becoming even more popular as the years go by. It's something that all ages participate in, which is pretty unique. This is not a sport that's like soccer or baseball that's really designed for young kids and younger people. But instead, we can see here, there's people in the 30s, 40s, 50s, even into 60s, 70s, 80s that participate regularly in running events. So definitely a unique kind of sport. Our goal as runners is pretty much to get from here at the starting point of any race, whether it's a marathon, half marathon, or others, to here, which is the finish line. And you can see the runners not looking exactly the same before and afterwards. And this is a 4.5 hour mark. These guys are actually not in such bad shape. And we really don't want to end up in here. This is the main medical tent of the New York City Marathon, which looks remarkably sedate on the outside, but on the inside is usually mayhem by about the 4 hour mark. As you can see, this is even before it's too mayhemish. And we really don't want to end up in here. At most of these races, we transport very few patients to the emergency room, but obviously these are places that you want to stay out of as a runner. So we'll talk about basically the principles of injuries, kind of how they occur, and then I'll go through sort of like a basic catalog of the injuries per body part, kind of what we get normally, and then we'll sort of wrap it up and come up with some ideas on how to prevent them a little bit. So biomechanics, most of our injuries are not traumatic injuries. Even in New York with taxis and crazy bikers, most of our injuries are going to be repetitive stress. Basically, the act of running is a very high amount of stress across each body part in the legs and back and other muscles. And these body parts, in general, receive these stresses and react to them. And most of our injuries are reflective of that. The lower extremity has some of the highest forces of anything. You can see here the knee can get up to 7-11 times body weight during the course of running. The tibia bone, the Achilles, the ankle all receives a huge amount of stress across these bones. These are all things that are well compensated for. Our bodies get used to this if we do it properly. But it is a lot of stress, and that's why we end up with many troubles. What I tell patients all the time is they always ask is, why did I get this injury? Why did this happen? It's because running really is an amplifier of minor problems. Everybody's got tightnesses, weaknesses, alignment issues, and asymmetries, things that are different about them per side, per muscle group. Those are not a big deal, but when you apply the repetitive stresses of running, you can amplify those into something that can turn into pathologic issues. So the theory behind injury really is that everybody has in their own body this threshold where as long as they do activities below that threshold, the body can self-repair itself. It can heal itself to the point that whatever abuse you throw at it, it's going to just simply heal each week. The problem is nobody really knows where their own threshold is, and that can vary per body part and per month and per week, and depending on what's going on. So an overuse injury occurs when we exceed that. When we go above that, that's where we can do it. On runners, it's easy to kind of look at miles per week or intensity. There's ways that we can quantify how much abuse we're throwing on ourselves, but unfortunately, nobody knows where this line is. I wish we all had like a threshold meter on our Apple Watch that could tell us that, but it doesn't exist. Some people have a high threshold. If you're from Kenya, you probably have a much higher threshold than if you're not from Kenya. If you look like this guy, then probably you have a lower threshold. And as we get older, unfortunately, that threshold does decrease. Illnesses, periods of inactivity can all drop that threshold down, and unfortunately lead us to injury sooner. So training is basically going below that threshold, just staying below it, allowing the threshold to creep itself up. And that's the theory behind all training programs. Basically, you start off light and work your way up. And everybody knows that if you start from running 10 miles a week and you go run a marathon, that's not a good recipe for success. Most people are going to end up with some type of problems, either during the race or especially afterwards. So the way we can condition ourselves to run these longer races and to run more often is by doing it slowly and ramping it up. So the other thing to think about is that when we do get an injury, that threshold, bam, all of a sudden goes down again. It's easy to get used to running 40 miles a week and training for a marathon. You get an injury, you take 2 weeks off, and then go back to running 40 miles a week, and then you get re-injured again. And think, oh my God, what happened? Well, what happened was is that unfortunately the threshold was 30 miles a week. You went back to 40 miles a week, and bam, you're back into trouble again. So it's very important when you're recovering from an injury to realize this as well. So the main priority for recovery from injury is to stay below that level and gradually allow it to build up again, just like we're doing in the course of regular training. So rest assures that we're going to be below the threshold. If our feet are up, then we're not going to be running, and we're definitely going to be healing. But that's troublesome to maintain if you're training for a specific race or you've got a specific goal in mind. So cross-training, non-impact activities, these are the way that we try to stay in shape while we're recovering from an injury. That includes things like cycling, swimming, elliptical machines. These are all the boring things that runners tend to hate to do, but at the same time become useful in the process of recovering from an injury to maintain fitness so you're not laying on the couch and losing everything that you gain. So other issues that can create injuries or at least have a role in it, alignment. Basically there are subtle abnormalities in the chain that can affect any part. So problems with the legs, alignment can affect the ankles, can affect the hips. Essentially, overall, you can see all kinds of different things that happen along that chain. And fixing any particular injury is always important to look at the whole chain top to bottom to see where you lie. So pronation, which people throw around a lot. If you go to Jackrabbit, they're going to be all over pronation when it comes to putting you in shoes and watching you run. What you want to have is sort of a neutral type of angulation. Unfortunately, many of us have some mild or sometimes even excessive pronation. And what you can see that does is you can see here it shifts up above here, which puts increased force across the knee and other body parts above. So pronation is something that's actually not so hard to control by simply changing your shoes around. So you can have intrinsic, which means part of you, and then extrinsic causes for malalignment. So for somebody who's got a little pronation, who's running in shoes like this that are super flexible, then you can actually cause some malalignment by essentially shifting the weight in a way it's not supposed to. So you can see here kind of what happens. This is fake pronation. This is essentially just somebody sort of tilting up on their feet. You can see the feet rising up here, and you can see what dramatic effect it has. The knees really go inward very quickly. But regular pronation, true pronation will cause that too. So essentially it creates increased effort of the muscles to stabilize your foot, more rotational forces, especially across the knee, and that can lead to trouble down the road. The knee and hip alignment can do that. You can end up with patellar tilt. This is a cut-off view of your kneecap. The kneecap is supposed to be straight down the pike here, and this one is off a little bit to the side. Shoe problems, even bad wear can do that. Not so much this you pretty much know a shoe is gone, but a lot of shoes subtly are going to get worn as they go, and you'll see the shoes just gently shift to the outside, which essentially can cause pronation. So poor fit, poor choice of shoes can be an issue, or damaged shoes. So flexibility, certainly an issue in terms of our muscles. This guy, probably not a major runner here. We all know that muscular tightness is not such a good thing. It does decrease the ability of our bodies to adapt to these forces that we're throwing at it. It increases the tendon-bone interface, so the tendons where they attach there, it's going to increase the stress across those. And it can even create or worsen the malalignment that we talked about previously. I always tell people that flexibility can be influenced by genetics, which Rockettes are chosen for what they can do, not just based on their training, but based on what they can do. And runners simply are not Rockettes for the most part. Hamstring tightness is a normal adaptive process of long-distance training, and most of us are going to get tight hamstrings as we go, and trying to become a Rockette while you're running is probably not a good record recipe either. Flexibility can be altered by environment. Cold temperatures definitely can alter, it can make you less flexible. The winter months are definitely harder to stay stretched out than in the summer when it's nice and warm. Dehydration can do it. If you get really dehydrated, that's going to make your muscles much less able to absorb the stress across them as well. So inflammation. This is also part of the natural process of healing, but it's also part of a pathologic process which can affect us as we run. It's a local response to tissue injury. That can be significant injury or just the daily injuries that we are doing as we run. And you get pain, swelling, and warmth. These are just inflammatory cells around the muscle. Inflammation, the response is oftentimes a little bit too much. So the body uses inflammation to heal an injury, but it also creates too much of it many times. And that can be detrimental to healing up an injury as well. Talking briefly about running surface, so different surfaces can create different forces. Running forces are influenced by the hardness and both by the regularity of the surface too. So in general, soft surfaces tend to be better for long distance training. For running, you get more variety, you get less impact, and you get more bang for the buck. If you can do a 7-minute mile on dirt, then you're going to be doing a lot better when you get to pavement where it's much more regular. Treadmills are oftentimes trouble because of that regularity. It's really the ultimate in producing the exact same forces. So I see runners every year who are amazed at how they got injured by running a short distance on the treadmill where they're used to running long distances outside, but simply changing the forces to cross the legs to something super regular can really create havoc on the legs that may.
I always thought that it was healthier to run on the treadmill rather than the grass.
Yeah, definitely not. There's definitely nothing healthier about it. You're better off outside for dirt, something softer. Nature needs variety. Your legs are used to having variety. Walking the city streets, our legs are constantly twisting and turning. The forces are very irregular.
So when you have that constant,
it's not the same step every single time. The only way to vary your steps on a treadmill is to basically fall off the treadmill. You can't do that anymore. You can vary the cadence, you can vary the angle, but every step is pretty much the same. So it's super important. I mean, treadmills are fine to train on. There's nothing wrong with training on them, but relying on them is your only form of training. Or most importantly, switching from outdoor running to treadmills when you're used to outdoors can be a good recipe for trouble. And I see it every winter time. Patients come in and can't believe they got injured on a treadmill when they were doing so much more running outside. So stress fractures. This is kind of, now we head into the portion of the program where we kind of talk about how things go bad, where things go south. So we all know that runners get stress fractures. Stress fractures are simply a failure of bone turnover. So bone is constantly, this is what bone looks like on our microscope, it's constantly getting destroyed and rebuilt. That's what our bodies do. That's what separates us from a machine. Astronauts, when they go into outer space, they run on treadmills, not because they think it looks cool and because they like to get a good workout, so they can run races when they get home, but because they lose bone mass by being in outer space for long periods. So treadmills mimic gravity. They put forces across the legs and to try to build up their bone. And it's a well-recognized phenomenon. When they go back from outer space, they lose a significant amount of bone mass even with these kind of treatments. So gravity is good to a certain extent. The problem is if the formation falls behind what we're doing to destroy our legs, then we get these stress fractures that occur. So the analogy I always use, it's like a paperclip. Basically, we are not paperclips. Our bodies can heal as we go, but if you bend the paperclip back and forth enough, eventually it's going to break, no matter how strong it is to begin with. So who's more at risk? Well, women are definitely more at risk, especially women who don't get periods when they're training so hard that they lose their periods. Poor nutrition can affect anybody, either eating disorders or simply just getting super aggressive with your dieting, trying to drop weight for a race to maintain to increase your speed. And anyone with osteoporosis, a history of osteoporosis, definitely is going to see a higher risk of stress fractures. How do we work on it? We oftentimes will get evaluations. We get bone densitometry to test how strong people's bones are. We get blood tests, and oftentimes we'll get somebody to look at people nutritionally to see what they're doing wrong if they develop one of these. X-rays are normal in stress fractures, which is always kind of freaks people out. They think if I've got a broken bone, I must be able to see it on an X-ray. So when I get an X-ray in the office and say your X-ray looks good, they say, whoopee, I don't have a stress fracture. Great. Until I tell them, well, they're usually normal on an X-ray anyway, so we got to still look at something else. So we rely on MRI scans nowadays. That's the most effective way to get a look at stress fractures. Stress fractures light up like a Christmas tree on an MRI. In this case, the white stuff right here is the bone starting to break. That little triangle shape is an early crack through the bone. And this is a hip joint right here.
And that's how it would show on an X-ray?
Not on an X-ray. This is a patient, I don't know if it's the same patient, but this is a completely normal X-ray, which is exactly what you see on a stress fracture. This could be the worst stress fracture in the world, and until the bone cracks into two pieces, then it's not going to see on.
So that's something like you would have to see.
Yep, so that's what we see on an MRI scan. So MRIs we use to see the extent of fracture. You can use it to look at healing, although it's difficult because it really lags behind. They're very slow. Sites of stress fracture, we can get them anywhere from top to bottom. It can happen anywhere in our legs. The most common sites are going to be the pelvis, which is around here, the hip right there, the knee down here, or the ankle or the foot are the common areas you can see it. So most stress fractures are going to heal with simple rest. That's a good thing, because they don't require a whole lot of crazy work. It's just basically putting the shoes in the closet and not running. And that can range from 6 weeks to 6 months, depending on the severity of the stress fracture, the location, the danger of it breaking. So now's our little catalog time. We'll just run down. I'm going to start from top to bottom and just run through the basic injuries we see. We'll start with the hip just to begin with. A lot of what we see in the hip is going to be muscular stuff, hamstrings especially, or hip flexors on the side, on the front, adductors, gluteal muscles. All of these are prone to tendonitis, where you get some inflammatory changes. A lot of these are managed by simply resting or doing some light stretching, but many of them become more troublesome and need some work with all the folks here and such. Trochanteric bursitis or hip bursitis, you'll see a lot. Runners get it, non-runners get it. It tends to be tenderness and pain kind of on the outside over there. It also is something that affects runners pretty commonly. You can see here, this is an MRI. All this white stuff is inflammation. It's just basically on the covering of the bone there, not within the joint itself. But hip bursitis is running injury you see rolling around. Stress fractures, again, we'll kind of go through some stress fractures as we go, but the pubic ramus in the front or the pelvis in the back is another common area for this. A lot of professional runners get this from being super aggressive as well. The sort of scariest of the bunch here is the femoral neck stress fracture or the hip stress fracture that runs across this area here. The reason why it's an area that's prone to it is it's a super high stress. You can see the hip bone makes an angle right there, so all the forces are concentrated in that one area. That one area is quite strong, but sometimes not strong enough. And this area is where we're going to see these things start to break. The big problem with hip stress fractures is they can progress to a full fracture. You can kind of see here that little sort of notch out of here represents the beginning of a crack all the way across. And this is what happens. You end up on the ground in excruciating pain. And virtually every year at the New York City Marathon, we have a runner that's in the middle of the race that falls down, can't get up. They get an ambulance, take them to the hospital, and they have a broken hip. It happens almost every year at some point across the from the running. It's developed before the running. This doesn't develop during the race, but these are people who become patients who had hip pain, ignored it, said, I can run 26.2 miles, I'll rest it a week before the race.
Can it be from improper stretching?
Doesn't really happen from improper stretching. It's really more of an overuse thing. But it's something that we try not to ever miss. So these things need immediate surgical treatment, plates and screws, kind of scary stuff that nobody wants any part of. And it can have some long-term consequences too, which is not so good. So we'll keep moving south. Knee pain, we see a lot of knee injuries with runners, knee problems. The most common is runner's knee or patellofemoral syndrome is a Latin term that we use for it. Basically, it's pain in the front of the knee. It oftentimes occurs with going downstairs, sitting with the knees bent in a couple hours in a movie theater. Very common issue that we see with runners. And again, it's that overuse injury that has to do with something that's wrong to begin with. So people tend to have some tendency towards maltracking. The kneecap slides a little to the side, never something that's a big deal for walking the city streets. But running 40 miles a week, all of a sudden that becomes an issue. Increased stress across here leads to pain. Pain creates weakness. Weakness creates tightness, and you just get stuck. On the other side of the knee, on the outside of the knee, is what's called IT band syndrome or iliotibial band syndrome. You definitely see a lot of this in runners, and if you read any running magazine or anything else, you're going to see tons and tons of articles and stuff about it. And it's basically pain on the outside portion of the knee, so it's kind of right over here. You can usually put a finger on it, and it's reflective of basically this IT band muscle, the red one, rubbing back and forth across this piece of bone right there. That creates inflammation. Inflammation creates more tightness, and the whole thing just kind of gets stuck with you. So IT band syndrome is super common, and they'll definitely talk a bunch about that when we get to the therapy session. Knee arthritis, always something that people want to know about and talk about and think about. The old question is, does running cause arthritis? My mom probably still calls me once a month to tell me that if I don't stop running, I'm going to destroy my knees, despite the fact that there really is no association between running and premature arthritis. There's lots of different articles where they've gone and looked at people who run regularly, and they've not found that people who run regularly are going to be at a higher risk for this. The problem comes. This was a study where they looked at after a marathon. They MRI'd people before and afterwards. MRIs being super sensitive for any kind of damage to a joint. Completely normal looking MRIs right after the race. So yes, there's lots of things that can happen during a race, but destroying your knees isn't really one of them. So the reason why it does get complicated is that in general, running is not really recommended for patients who have knee arthritis already. So if you have arthritis and you try to run, then you're going to get into trouble. So I routinely have patients come into my office who start running, they start developing pain, I x-ray them, and they have arthritis. And I say, well, unfortunately, this is something that's not so good for running. And those are the patients that they get things confused. Oh, I must have caused the arthritis by running on it. It's not a cause, it's really just the effect of running on a knee that's already got some wear and tear to it like this one does. So moving down the line, shin pain or lower leg pain. is common as well. Most of what we see here are going to be what's called shin splints, or the fancy term that we use for it is medial tibial stress syndrome, meaning stress across the bone here. This is on the lower third, the inside part of the leg is the most common place to see this, although you can't see it further north. And this is characterized by inflammation outside the bone. Once again, on an MRI scan, anything inflamed shows up as white on these type studies. So you can see all this white stuff all around the bone, and this area here represents some pretty nasty shin splints, basically really bad stuff, super painful. But the bone itself, you can see, is super pristine, white, black as can be. There's no white in there, meaning that the bone is not cracking. Doesn't mean this is good for running, but at the same time, it's certainly better than having a stress fracture.
What would be like a recuperation for that type of injury?
I'll talk more about that when it comes to the therapy sessions for sure, but it really depends. I mean, for that amount of information there, you're looking at like a good 6 weeks probably to get back and running on that. So shin splints, it's one of the characteristics is the pain is sort of mild during the run, but as soon as you stop, it starts to get worse and worse until you're kind of limping afterwards. That's contrasting with a tibial stress fracture or a stress fracture of the tibia bone, which is the opposite. Basically, this is going to be pain that's more commonly north of there. It's going to be closer to the knee joint, is where we see most of those. It's usually up in that area. Here you can see two stress fractures, one right across here and one right across there. Those are definitely going to be ones that are going to be more painful. And these are going to oftentimes be found sort of as you run. So it's more of I start to run, it starts to hurt, it gets worse and worse until I stop. So it's a little different characteristic. An MRI, of course, is a good way to look at this. You can see here, now we've got bone swelling outside the bone, but look at it inside of the bone. It lights up super white right in there. So that's definitely abnormal in the beginning of a stress fracture. Most of them are, I'm sorry, so that was for the tibia. The fibula bone, which is a little bone right in that same neighborhood, is also prone to these, and we see a bunch of those. Those typically be further down. They can be closer down to the ankle joint, but you can also break that bone too. Last but not least, posterior tibial tendonitis, which is a muscle on the back part of the leg. The back and inside part is also going to be painful. It's sort of similar to to a shin splint. It's just a different location. It's more like a deep calf kind of pain. And that's also going to get worse kind of after you run. It's more commonly seen. So last on the list of the lower leg problems, which are numerous as we see, is going to be what's called compartment syndrome. This is also something you'll see in a bunch of running magazines and such. It's basically a condition where the muscles lose their resilience, they lose their ability to absorb stress, and they start to swell within these nice well-defined compartments right here. Because they swell, they start to create pressure. The pressure creates basically pain and can even create muscle damage if it's left untreated. For the most part, this stuff is benign. It's treated with physical therapy and resting, but it does sometimes get worse than that. This is going to be pain during the exercise. You can get what are called paresthesias, where they get a little numbness in the area, and that it tends to stop right as you finish a run, which is a little different than the other ones. So we measure this by putting a little needle in the knee and the leg, which doesn't sound so fun, and it's not that fun, although we numb them up first, and put them on a treadmill to measure that, and even sometimes requiring release. This is a surgical release. We have to go in there and open up the compartments to get people back to running again. There's a few professional runners that have had this done. Last but not least, moving down, we're almost down to the end here. We got foot pain. So plantar fasciitis is a super common cause for running problems. It's pain in the heel. It's very characteristic. It's pain that usually is in the morning. It's usually going to be occurring when you first get up and you first take a step or two. It sort of oftentimes stretches out as you run and feels better, and then afterwards hurts again. It tends to hurt more if we're kind of walking around during the day. Let's see, next on the list, moving down, stress fractures. The foot is a common area for stress fractures, both runners and non-runners alike. You can see here a bone that lights up here in the metatarsal bone in the forefoot here, and then a bone in the midfoot further north than that lights up. These are all common areas that we see trouble, and anybody that's got pain and swelling that's running a lot, we can treat these kind of seriously. So Achilles tendonitis, which is very common too. The Achilles is kind of this sort of like high stress area. It's vulnerable. It tends to be where we see a lot of forces concentrated, and we get a lot of pain in that area. That's characteristic by you get pain that's right in that Achilles area, and that also sometimes will stretch out as you run and then sort of feel worse later on. Other foot problems, blisters, very common. That can be from poorly fitting shoes, either too small or too large. It can sometimes be subtle, and you can get blisters here. You can get them in other places too. We treat these typically if they get big enough in the medical tent when they come in. We drain them, we try not to pop them because this layer above it acts as a good barrier protection while the skin underneath it heals. But it's really easy to slip a needle in here and just suck out all that blood and sort of flatten it out. And that surprisingly isn't painful at all because this skin here has zero sensation on it. Preventing it, Vaseline is an excellent way to do it. I myself slather my feet monstrously before any kind of major long runs, and for the most part, I've been pretty successful. These double layer socks sometimes can be helpful as well. Prevention, like we talked about, basically size, and sometimes even just the brand of shoes can do it. All it takes sometimes is just playing around with those. Last on the list would be at the very tips of the toes. We get these ugly looking nails here. We get some bleeding on the nails where they turn black. It seems really super painful and it seems terrible, but it's actually not. It's pretty benign, and most people just don't have any pain there at all. Occasionally the nails will fall off. If they do, it's not of any concern. They eventually just grow back. So recovering, we're talking about it briefly. Essentially, we want to do local treatment. Ice is excellent for that. It's kind of nature's best anti-inflammatory. It's best used after exercise activities and can be very helpful. Medication we use a lot, either Aleve, Advil, Celebrex, Meloxicam. There's a dozen different ones that are out there. These all, again, blunt that sort of over-exuberant response of the body by putting too much inflammation into an area that's been injured. We use some non-steroidal creams and patches. This is a gel, this is a patch. It's kind of like a liquid Advil or a patch form of Advil that works pretty well as well. So we can try to realign things. We can't realign people structurally without cracking their bones open, which is no fun. Instead, what we can do is try to let the body readapt itself, and that's by improving flexibility, improving strength. This is what's going on over there in that side of the office over there as people get treated with all different kinds of therapy modalities, and how people treat themselves at home as well. So stretching, we know it increases flexibility, it decreases stiffness and strain. We do tend to prefer dynamic stretching, which these guys are going to talk a lot about. Stretching also can increase some control of your joints, so basically you can control the joints better as you get them strengthened, strong, and well balanced. Shoe changes can help. Getting into more stability or motion control shoes, if you have a tendency towards pronation, can help. And even sometimes orthotics can be useful. I'm sort of a medium believer in orthotics. A lot of podiatrists will claim that you can cure ear infections if you put the right insoles in people, but they definitely are widely prescribed. I think that for some people they can be very helpful, but in general, like, we try to fix them sort of up north first before we resort to shoe changes down below, to orthotics below. Gait analysis, these guys will talk about that, can be very useful in trying to figure things out, trying to figure out where people are running and how it's affecting their legs. And other modalities that these guys will talk more about, ultrasound, laser, massage, all kinds of cool toys. We in the office use a lot of cortisone. Cortisone is a really helpful tool for getting rid of inflammation when it's a very localized area. It works really well for an IT band and for plantar fasciitis. It tends to be sort of a big gun and something we take out when patients are really in trouble or really trying to get time sort of tuned up before a race. But it's essentially like taking a bottle of Aleve and putting it right in one single spot. It doesn't work globally for different muscle groups, but it works well when it's a localized problem. So PRP, I throw it in there just because people always ask about it. It's a process where we take blood out of the body, spin it down, and take just the platelets, which are these guys here. It's sort of a localized anti-inflammatory. It's got a lot of good healing cells, and it has some role in treating disease, running problems. It doesn't have a great track record of sort of clinical success when it comes to studies and literature, so it's still kind of experimental and it can be kind of costly, but we still use it from time to time for patients who kind of failed everything else. Talking about injury prevention, it kind of makes this stuff all sort of make sense based on what we'd already talked about, but essentially not overtraining is a key to preventing injuries. You want to basically stay below that threshold. There's a 10% rule that they throw around all the time. Essentially, if you don't increase more than 10% per week, then it should be relatively safe. That's going to vary depending on your genetics and who you are and how fast you're going to ramp up, but it's sort of something to kind of keep in the back of your mind. You want to keep some rest days as part of any schedule. Even the professional runners are still taking a day off a lot of times, or at least take a very light day compared to what they do for the rest of the week. And it's important to give your body some chance to heal up as you go. You want to build up leg strength, and it's sort of like a weird thing where you work out at the gym and people know you're a runner and they say, why are you doing leg exercises? You're a runner, you're running 40 miles a week. Why would you want to strengthen your knees? You should be building up big, strong muscles up top. And the truth is that strengthening the legs in different ways in the gym is going to help us in ways that the running is not helping us. Running tends to be a very hamstring-intensive sport, calf-intensive sport, glute-intensive sport, but it doesn't do that much for your quads and other muscles around. So core strength is super important. The stronger your core is, the less work your hips have to do, and that certainly is going to be something that's going to be helpful for runners. Many runners are super leg strong but not core strong, which can be a problem. Rapid fashion can be helpful. So you want to vary your train, including some soft surfaces can be really helpful, especially if you're going to be doing longer distance stuff. To mix in some dirt at some point can be very nice. And in general, treadmills can be trouble, so just be careful of them if you're going to use them for long distance kind of stuff. There's no reason why you can't mix some treadmills into a weekly running routine, and if it's pouring down snow, it's fine to use it, but at the same time, just be careful of them. You want to keep well-fitted, updated, appropriate shoes. You don't want to let them get too beat up. And depending on what your alignment is, you may need something that's even more stable. This is sort of the ultimate instability shoes and cushioning that's out there now. Hydrating well is really important, not just for preventing dehydration, which can lead you to the emergency room and cook off your kidneys and do something really bad, but it's also important to keep your muscles happy so that when you're running, they don't get injured. Nutrition is super important. Calcium, vitamin D, good for your bones as you train. Simply making sure that you're getting enough calories in your diet is important. It's natural to lose some weight during the running program if you're going to be training for a race, but you want to monitor that and make sure that it's not too excessive. So scale is a pretty good way to check that out. So basically in conclusion, overtraining, number one cause of most injuries is just about how much, how fast, how quickly you do it. Recovery is going to be dependent on how fast you return to running and how careful you are doing it. You always want to look at the entire chain if there's any kind of a problem. So if it's a calf problem, you want to look up at the hips to make sure that that's not the culprit. And we want to take hip pain seriously. That's the one area if it breaks, it can lead you to the operating room, which is really bad stuff. So if you're getting hip pain, always something you want to get checked out before you get out there and do a long run and find out the hard way. That's all I got. Questions? Yes?
For like a shin stress fracture, how would you determine if someone would need to go get an MRI?
Well, I mean, so essentially everything we do, when a patient comes in, they say, all right, what body part's hurting? You look at the body part, you kind of listen to the history to figure out sort of what it seems to match most, and then you kind of decide whether or not it's something that warrants an MRI or not. Depends on the location, depends on the intensity, depends on what it looks like when you examine them. If they've got point tenderness right over the bone versus point tenderness on the muscles in the back, that leads us to different things. I mean, depending on where they are, I mean, certainly for runners in a marathon training program, we're pretty aggressive on getting MRI scans, mostly because people really want to know. It's not, if they're 5 weeks away from a marathon, banging out 20-mile runs, and they've got a stress fracture, they kind of prefer to know about it before the next 20-mile run rather than during the next 20-mile run. So we do tend to get them fairly easily if it's somebody who's training pretty aggressively. If you're just recreationally running, you're not really training for a particular race, then a lot of times we'll just rely on sort of what it feels like, what it sounds like, and what the patient's complaining of. Questions? Guess you know it all.
Yeah. Good job. Thank you, Dr. Rosen.
Excuse me. And with an injury that we have to rehab, right? And we also really like this injury prevention topic because I myself, being a runner and a triathlete for quite a while, know that this is just the key to my doing this until I'm 80, 85. I want to be that old guy with the greater New York crossing the finish line that Dr. Rosen had up there. I'm not too far away these days. But anyway, that's, I think it's really, really important. We all love to run and we want to keep running. So that's where we come at this. So just the basics, we're going to talk a little bit about running form, self-myofascial release, which is a fancy way of saying foam rolling. Some of you are familiar with foam rolling, some should be familiar with foam rolling. We're looking at dynamic stretching. Dr. Rosen, said dynamic is the way to go these days. It's true, that kind of old school, hold the stretch for 30 seconds, For someone who wants to get up and move is kind of leaving, and we're looking more at dynamic stretching and mobility work. Strength and stability training. You know, when I was a high school runner, this was not part of the program. We did not strength train. And I think, and there's still a lot of high school and college teams out there that are missing that. But I think it's crucial. It's injury prevention. I think you start your early season with a lot of strength training, and as you increase mileage, that may die off, but you've got to prepare for the stress of running. You are hopping from one foot to the other for a very long time, so you need to be able to balance on one foot, lunge on one foot, and hop on one foot without pain. Hydration, Dr. Rosen talks a little bit about hydration and nutrition, very important, obviously. So running form, you see so much out there. And this got really, I guess, popular when the book Born to Run and the Vibram Five Fingers came out. Everybody started running with the weird sailor shoes. And the idea was that when running barefoot, that you would be more likely to land on your forefoot or your midfoot and in turn be less injury prone. That's being debunked a little bit now. So, and you don't need to go buy a Vibram Five Finger or run in the park with no shoes to be able to change how your foot lands. Obviously the foot's the first thing that hits the ground. You need some shock absorption. But one thing that I like to look at, and we'll talk a little bit about like our running gait analysis and that kind of thing. Some of the pros land on their heel. So heel striking and all its like negativity, sometimes it's not so bad. What I like to look at is the position of the knee when you heel strike and how quickly you get over that foot. So someone with a really long stride, like a lot of the pros, they might land on that heel, but they're not on it for very long, and they're not on their foot for very long. So that's something we're working on in practice with like the running drills and the high knees and the butt kicks and the shuffling, getting that turnover a little bit higher. One thing that you do see across the board with runners that happen to be less injury prone is this cadence, the number of steps you take per minute on one foot at 90. So what I like to do is when I'm running, and you can now get, I mean, the watches are so fancy, I'm a little bit old school, I still count. So the watches now tell you what your cadence is. If you're at 75, 80, you're spending a lot of time on the ground. See that plodding? I hear it in the clinic when I watch people run. You hear it, right? You watch those pros, those really fast people, they're springing off their foot and they're doing it quickly. So you can count per 20 seconds and multiply by 3 per foot. You can get a fancy watch. You can come see one of us. Something like that. But you want to work on that. And that's what we're doing with the running drills. So when you're doing high knees and butt kicks and things like that, you're thinking of that soft feet. It's a forceful sport. And you think 90 steps per foot per minute times however long you're going to run the half marathon or marathon, that's boom, boom. You want to spend less time on the ground. So when we start off practice and we do our lamppost drills from one to the next, that's what you want to be thinking about. Soft feet, tell your neighbor, I hear you, chill out, like soft feet, keep it fluid. We've got to practice running without running, so that's one way to do it. So we'll keep that up. And we've also, we've been including these videos at the bottom of the weekly email. And some of those videos, every one of them has a running drill in them. So you can look at like different ideas. A lot of things, they're all out there if you look at Runner's World. The one thing we do a little bit differently here is we move in all directions, a little bit more so maybe than some others. So you can do high knees, you can do them forward, you can do them sideways, you can do them backwards. Right? You can do butt kicks, same thing, right? You're working different parts of the foot and different parts of the reaction of the body to the force of running. So, self-myofascial release. All right, let me have a volunteer.
I didn't know if you came early.
Who we got? You want to volunteer? All right. You have any injuries? You healthy? Not right now. All right. Healthy? Yeah, that works. Thank you. All right, so this is kind of key. I recommend this after long runs, hard runs, unless you've got a massage therapist coming to your house every day, which would be awesome. I would say maybe invest in one of these. So just a quick couple areas to hit are quads and calves. It's really easy to demonstrate and show. You can do this, and these come with like how-tos, so you can learn. Our videos as well, they have how to do this. I get a lot of people that are like, yeah, I think I have one of those. It's like, it's the other day, my husband put it away, like we don't know what it is. All right, we're gonna pull it back down, start using it again as you train for the marathon. So what we're gonna do is we're gonna hit the quads real quick with this, and the calves. And I recommend, so go ahead kind of down here in kind of plank position. Perfect. Do you foam roll?
Yes.
Look at this. This is like she knows what she's doing. So she's great. So I'm going to pick on her because she does foam roll. She knows what she's doing here. She's in a nice plank position, getting a core workout, right? TV's on, end of the day. You're just multitasking here, right? What you're going to do now is go down towards the knees again. Good, and hold there. We're going to go a little slower, all right? A little slower, and I want you to bend and straighten your knees a few times. While you yeah, just keep the roller where it is. Good. Bend and straighten. How's that? So what you're doing is you're putting the muscle on stretch and then shortening. Putting it on stretch. All you're doing here is improving circulation, blood flow, enhancing recovery. There's a lot of studies out there now on foam rolling. Now that we're doing it, it does improve recovery time, enhance performance, so that that soreness doesn't take you. If you have a Saturday long run, you don't want to feel that soreness on Monday. You do this afterwards, and then you can move up a little bit higher or lower. My higher is your lower. So think of the quadricep muscle in thirds, right? And work each third of that muscle. Bend the knees again and straighten. Good, and a little higher. I just read, now there's a lot of, some people say, we get this question, do I roll the IT band? You know what the IT band is? Right? It's this thick, Dr. Rosen just talked about it, you get this IT band friction syndrome, very, very irritating, painful tissue. But you don't have to destroy that tissue with a foam roller to make it better. As a matter of fact, there's stuff saying that's counterproductive now. So you can work on the quads and the glutes with the foam roller without, and that's super sensitive, without going right over that IT band, and do this kind of thing. All right? Now we can go on the calves. So you can kind of turn around, have a seat, put one leg up. So she was doing both legs at once. You can do one leg at a time. Look, she's like a pro. Moving the foot up and down, right? Change the length of the muscle. These are the coolest shoes I've ever seen on the foam roller. And you got to think of the muscle as a whole. The side of the muscle, both sides. And then again, up and down. So changing the length of the muscle. Good. And then the inside. So take your time. You see a lot of people just drilling their muscles with this thing, doing it as fast. Think of the type of massage that you would want to have. If I have a patient come into the office, I'm not just like, you're just taking the time, improving blood flow, nice soft touch. You don't have to, turn red, go to another part of the muscle.
I have a question.
Yeah.
For the IT band, like if you don't have any pain, but you can kind of feel like it's knotted up a little, is it still bad to roll on it, or?
Yeah, you don't. It's more out there saying that you're never going to change the structure. It is an inherently thick, strong structure that you want. A lot of the IT band stuff is there's a mechanical issue going on. When I had it years ago training for triathlon, and it was foam roll it. But there were underlying mechanical issues that were going on that were causing it, and that's what's important to get to with all this stuff. Like Dr. Rosen said, if somebody comes in with a calf problem, we got to look at the hips, right? It just makes sense these days. So it should feel like a firm tissue. It is. It's thick. It's not a muscle. It's thick fascial tissue, and the thickest in the body. So, and you'll never change its structure with something like this. So I recommend the quads, the hamstrings, the glutes, kind of working around it. People get on that IT band, they're like, oh yeah, it's good, right? It's like, it doesn't look good. It's okay. Like, you don't have, like, this is not the hardcore, old school, like Texas high school football coach style where everything has to be intense. And I'm from Texas, so I can say that. Also, you can think about going like side to side a little bit. So she's pretty good, you know, she can take some force on here. You can put the other foot on top, things like that. Yeah. So calves, quads, keeping tissues loose. As I've aged, I used to just do this after a run. As I've aged, I get a little more like stiff and tight muscles in the morning. Sometimes I do it before. Either is okay. Before, I think about it as just quicker, warming it up, kind of getting things going. After, I think is recovery. Decrease that soreness so that you can go into the next workout, have a good one. All right? Do you like the color orange? Congratulations for being a wonderful demonstrator. You won yourself a great foam roller. So this is a nice little chart, and I really like how this plays out. You know, we're not Usain Bolt. We don't need a ton of range of motion for distance running. But you do need some, right? And so we see some people, and you go into just a neutrally extended hip position, and that's about it. Like, okay, well, for running, we want a little bit more, right? So we use that. Here's the range of motion you have, right? That's what you need to run successfully. You think of it as a circle, too, because the body moves in all directions. But to be that 80-year-old guy that crosses the finish line, I'm going to bank some now so that I know as tissues change, as body structure changes, and that I have the capability to do this for a very long time. Because at the end of the day, that's what it's about. Like, I think it's great that everybody's doing this year, right? I want to do it in 10 years and 20 years. So it's a nice little way of thinking about things. So how do we get that? Through dynamic stretching. So we see a lot of people that have what I call sagittal plane injuries. So they're injured from running and moving in this direction, right? So sometimes they can't tolerate stretching or strengthening in that same direction because it's the same thing. My knee hurts when I run, then I'm probably not going to give them lunges. I'm probably not going to have them hopping on that leg. Even that tissue can be irritated enough where stretching it in that direction might not be the best thing. So you don't just have to stretch forward, right? So some of the stretching we've done before practice, it's that lunge matrix. You're reaching all directions. You're rotating your torso. You're lunging to the side. You're doing the same, right? The body's moving in all directions. You get subtle little bits of rotation throughout, even though it's a primarily sagittal plane activity. The foot and the ankle rotate a little bit. The knee rotates a little bit, hopefully not a lot. The hip, right? Those are things to work on with stretching. Dynamic, especially if you're doing it before a run and if you've been stagnant for some period of time, i.e. if you've been at the desk for a while, or if you've been sleeping. You know, I wake up, it's 5 o'clock in the morning, 2 shots of espresso and I hit it, right? Like, take 5 minutes, just a little bit. Dynamic stretching, move before you move. So again, the lunge matrix, if you work with any of us, a lot of things are matrix. We balance matrix, we lunge matrix, we plank matrix. They stop saying matrix, but it's effective because you're moving in all directions. And it really opens up the hips, right? So again, you know, somebody could have knee pain when they lunge forward. I've had people that come in and it's fine when they lunge to the side. They're getting a nice little hip stretch on the side. You can work that until they can tolerate things like lunging forward, stretching forward. all directions, all of our stretches, all of the stuff that we put out there is multi-dimensional. When we watch you move, these running analysis don't just have to be running analysis. I like to watch people move after them. So they run on the treadmill a little bit. Running's weird because you can compensate so easily when you're running. So then you get them doing single leg stuff and moving in different directions. You really see what's going on with the body. Again, this is just like a no-brainer now, and I think most people are trending more towards it. I think there might be some more old school coaching and things like that that are like, no, you don't want to like get big and bulk up. But again, it's like Dr. Rosen said, you got to stress the muscles that you're about to stress. We do a lot of this early season. So right now, I myself, 3 times a week, I'm doing a strength workout. As the thing goes on, I might not do 3 times a week. But I didn't run in December, and I know I want to run in March. So I'm not just going to start cranking at it in January. Stress the running muscles as they're to be stressed, and get ready for what you're about to do, so that you can do it healthily all year. So this is a little formula that we use just to make sure you're hydrated. Again, we're water. We are made of water. And so you want to make sure that you're staying hydrated throughout the day. For my patients and clients that have desk jobs, I say this is a great time. Like, use hydration as a reason to get up out of your chair. Go refill the water bottle, so you're killing 2 birds with 1 stone. You're moving, and you're hydrating, right? When tissues get dry, when muscle tissue and fascial tissue gets dry, it does not move well. So not just during running. I think everybody knows that's not like a no-brainer, but throughout the day. So if you drink coffee, or if you're going to have a glass of wine tonight, let's supplement it with a little bit of water as well. And there's a little formula for that at the bottom. This is probably like, you know, you can just see it in a patient's eyes that this is really what they want to ask. Like, they're all, yeah, they're great. I'm happy to see you. I want to know why I'm injured. And can I run? Can I run? Okay, so we use kind of a subjective pain scale, right? So, and there's the 0 to 10 pain scale, but that's different for everybody, and what's an 8 and what's a 7. I like to say mild, moderate, or severe pain. If you have severe pain and you're going for a run, we'll have a discussion later. Even moderate, right? If it's moderate or severe, just standing around, walking around, don't run. If it's mild, sometimes mild stiffness, things like that warm up and it feels better as you run. That might be okay, but you also need to check in after the run. Some tendonitis and things like that, they warm up, that blood starts flowing, and then you immediately stop and it cinches up. So create a scale for yourself and discuss it with whoever you're working with. Because we're not going, through any heroics here and trying to put people on the finish line. The pros will shut it down early, and I recommend that everybody else does too. So talk to your coach. The worst kind of injury, I love the last bullet point, is the one that's been around for 6 months. And yes, I think I'm, last year, year and a half, been there for a year and a half. I would so much rather you come in 2 weeks, right? And I've had my share of injuries too. They're so much easier to deal with 2-3 weeks in than a year and a half. So just, if something, we all get sore, right, from running. So you got to think, but if you have a hot spot, and it's the same place and the same time, right, every time you run, it's probably something to be addressed. Talk to your coach, talk to a doctor, a physical therapist, something. Cross-training. I actually like this. So obviously to come back from running, you don't just want to go back into it. But I also like it just while I'm training. I come from a triathlon background, so I still ride my bike. I can't take 50-mile weeks very easily. See what happens when you give me this fancy clicker device? Oh, fantastic. So I'll supplement my running with swimming and cycling and things like that. We have 2 of these fancy little Alter G treadmills at the other end of the clinic. They're a fantastic rehabilitative tool and also something to supplement training. They unweight you with air pressure. So you're in the bubble. In the bubble, you can run at 65% of your body weight, 70% of your body weight. It's a no-brainer way to come back from injury, but also a nice way to just supplement extra miles. So this is kind of from a course that I took last year, and I really like it from an overall well-being standpoint. Because yeah, we want to all be good runners, but we also just want to be good movers, and we want to have healthy tissues until we're 95 years old. So one thing that we see again is this sagittal plane athlete, right? So I'm a runner, I run in the sagittal plane forwards and backwards. And I say, well, what kind of strength training do you do? Well, I do squats, I do lunges, I do box jumps. I can't figure out why I'm injured. Well, everything you've just done is the same motion to me, really. So, right, it's supplementing, and it's these 4 boxes of where do you live. Most of us as runners live in the unloaded, no weight, just our body weight, linear pattern of motion. You run a higher risk of injury it's a repetitive stress injury if you move in the same way, in the same direction, at the same speed, multiple times a week. So you supplement that with strength training with weights, moving out of that same linear pattern, doing rotational exercises, doing yoga, doing Tai Chi, moving in other ways, a couple times a week, so that you don't stress that body in the same way, in the same direction, at the same speed, over and over and over again. So this is a little bit more about we call it a peak performance analysis. It's a fancy way of saying, come in and talk to one of us. You can use it as a gait analysis session. You can use it as a golf analysis session. You can use it as a recovery session. Available to all Team for Kids participants. We would rather see, if you're running the New York City Marathon, this is a great time to do it, right? The half is fine too. You don't want to do this 2 weeks before a race, a week before a race, and then we say all these things about your running gait, and then you freak out and like, oh no, I can't run, I'm not doing anything correctly. So come in early. We're going to look at the full body, everything, how the head and neck moves on the torso, how the hips rotate, how the foot hits the ground. And see if I'm one of those people that every year I get shin splints. Every year my right knee hurts, right? I've done all the same things. I roll, I do this. What's the underlying reason? That's what you got to get to. And I think we're pretty good at that. So that's all for now. I hope to see you all here on Saturday for practice. We'll do some of this stuff. In the meantime, we've got Andre, our office manager, back here. If you want to talk to him about any of the logistics of coming to see one of us, talk to us. There's some handouts here. I'm here for a little bit. Let me know if you have any questions. Thank you, guys.
Thank you.
Thank you.